The Affordable Care Act mandates the formation of public health exchanges and provides for the expansion of Medicaid coverage. Both of these actions will impact employer plans, in particular smaller employers and employers with low-wage employees. With regulatory guidance, we now know that most employers who offer health insurance will meet the affordability and minimum value requirements of the law, thereby avoiding substantial tax penalties. Uncertainty continues despite a 2014 rollout as to how public health exchanges will work from a practical, operational perspective. Also, while many states have approved Medicaid expansion, at least 10 remain undecided. Public health exchanges are a hallmark of the Affordable Care Act. In theory, the exchange will serve as an insurance marketplace for the purchase of healthcare coverage. Pragmatically, the public exchange, at least initially, serves as a conduit for financial subsidies for lower-income Americans. An individual seeking health insurance coverage contacts the public exchange through the internet or a phone call. The exchange assesses family income information, and a determination is made as to which type of health plan makes the most sense for that individual, either a government-sponsored plan such as Medicaid or a subsidized metal plan as they are called, bronze, silver, gold, or platinum. Subsidies available through a public exchange will vary depending on family income. Individuals and families with incomes ranging from the maximum Medicaid eligible income and 400% of the federal poverty level will qualify. Depending on the state, the threshold where a family is no longer eligible for Medicaid will vary from 100% to 133% of federal poverty level. In addition to premium subsidies, a sliding scale of maximum out-of-pocket limits will apply based on income thresholds. If an employee has access to a health plan through their employer that is affordable and offers minimum value, public exchange subsidies are not available. In Massachusetts, subsidized healthcare access through a public exchange is a cornerstone of healthcare reforms enacted in 2006. The framers of the Affordable Care Act modeled much of the law based on these reforms. In Massachusetts, 230,000 residents are covered through a public exchange, representing 4% of the population. Of those enrolled, more than 80% receive some form of subsidy. As in the Affordable Care Act, employers are required to provide health insurance coverage or pay a tax. The number of uninsured has dropped to 4% of the population, one of the lowest percentages in the country. But while access to health insurance coverage has improved, healthcare spending per person has increased to levels that are amongst the highest in the country. Rather than create its own health exchange as allowed under the law, Ohio joins 26 other states in opting for a federally facilitated health exchange. 17 states and the District of Columbia are committed to developing their own exchange, and 7 states are creating what is called a state-federal partnership exchange. In many ways, Ohio reflects the country as a whole with income levels, healthcare spending per capita, and the number of uninsured reflecting national norms. Based on demographics, it is likely that the percent of population that accesses health insurance coverage through a public exchange will be greater than Massachusetts, but less than states where average income levels are lower than in Ohio. Private exchanges are part of the developing dialogue in the reshaping of healthcare delivery. Unlike a public exchange, private exchanges are unable to provide government-funded subsidies. In addition, self-funding approaches that are popular with employers are difficult to implement under such an approach. Advocates of private exchanges highlight the defined contribution approach that allows an employer to provide a fixed dollar amount towards premiums, lessening the impact of healthcare inflation on corporate budgets, and the ability for employees to choose multiple health plans for multiple insurers. While there has been a lot of discussion and promotion of private exchanges, to date, engagement has been limited. Expansion of Medicaid from 100 to 133% of the federal poverty level, as mandated by the Affordable Care Act, is now a state-by-state decision due to a U.S. Supreme Court ruling in June 2012. Many states that were originally opposed to Medicaid expansion are now embracing it as the promise of additional federal funding becomes a reality. To date, 24 states are participating, 15 are not participating, and 11 are undecided. Ohio continues to be undecided as it continues to work through a political process. While the Affordable Care Act calls for the expansion of Medicaid coverage to 133% of federal poverty level, The calculation is really more complicated, as each state has different guidelines for eligibility and previously approved federal programs, such as Children's Health Insurance Program, or CHIP, provide coverage to families with incomes up to 200% of the federal poverty level. Under the Affordable Care Act, the interplay between an employer-based health plan and government-sponsored programs, such as Medicaid and public health exchanges, need to be considered in the development of an employee benefits strategy and philosophy. While many issues are yet to be resolved, it is clear that a great number of Americans will be eligible for expanded government entitlements. The Affordable Care Act is having a profound impact on employers, healthcare providers, and individuals. The Fedeli Group stands ready to help you navigate the complexities of this law.